Hi, I'm Dr. Faranak Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
We are back with Dr. Tina Bhutani. If you listened to our last session one of this, Dr. Bhutani, who of course we all know very well, but she is the CEO of Synergy Dermatology in San Francisco and associate clinical professor at UCSF and the previous co-director of the UCSF Psoriasis Center, an absolute expert in psoriasis, inflammatory skin care, atopic dermatitis. And in our last session, just a quick recap, we highlighted the importance of kind of our paradigm shift of how we approach topicals.
Yep.
Kind of going from the steroid
steroid
world
era
that doesn't have to be steroid first.
Yeah, to now, having a whole new toolbox of newer non-steroidal agents.
Yeah, and what I learned from Dr. Bhutani in the last one is, we talked about roflumilast, Zoryve. One, I learned how to correctly say Zoryve.
It. Yeah.
So that was important. I feel like that was 90% of the information that I needed. But also, I think that really interesting takeaway was just how well it's formulated, which is really key with topicals. But of course, we know the elegance of topicals in dermatology is so important, not only for effective and bioactivity, but people want to use it.
And exactly. They want to put it on their skin.
Yeah. To put it on their skin. And you talked about the foam, really high satisfaction rates. So now we have a solution. It works. And let's see how the efficacy works out. And actually, if you want, maybe before, at the end of the last session, we did talk about what percentages for what indications. If you want to just recap.
You can review it again. Yeah. So Zoryve has 3 indications: atopic derm, psoriasis, and seborrheic dermatitis. For atopic derm, there is the 0.15% cream approved for ages 6 and up. For psoriasis, there are now 2 formulations, a 0.3% cream or the 0.3% foam. So there's two formulations. The cream is approved for ages 6 and up. The foam is for ages 12 and up. And then for sebderm, it's also the 0.3% foam, the same foam, but it's approved down to 9 years of age in sebderm, because that's the time that we think, adolescence, hormones, oils start flowing, hormones start changing, and that's when people start to get sebderm.
And that's like a group you want to give one thing to that works quickly.
Right.
Like, you're not messing around with, you take your hydrocortisone and then you rotate it around with your ketoconazole. So there's no way a teenager is doing that. We know that from our acne world.
Yeah.
They're not doing any of that stuff. It has to be together. It has to be nice to use.
Yeah.
So going off of that, it's so great to have this kind of information. Let's say patient comes in, and then let's say they probably have been on a steroid, right? Like, usually, especially because we're kind of in multi-specialty clinics, it's rare to have somebody come in there where they haven't used anything.
Exactly. And I think at this point, even primary care doctors are comfortable with prescribing some type of steroid. It might not be the right strength, it might not be the right formulation, but they'll have gotten something at some point.
They'll have gotten something. So you're probably, as far as getting things cleared and covered. So if you write it for the right indication, right percentage, and usually you probably do have to fail a topical steroids, which most people have.
Right. Yeah. I think in my experience, most of the time, they want you to have at least tried and failed one steroid. There's certain plans where they will also want you to fail another non-steroidal. So if they've tried, like, again, a tacrolimus protopic in the past or something like that, I would definitely throw that in there. For sebderm, ketoconazole shampoo does count as the tried and failed, and also over-the-counter dandruff shampoo in many cases will count against that.
That's a great tip.
So if they've already tried Head and Shoulders or whatever it is, definitely put that in your note as well.
That's a good tip. Like, just write these things down. If you don't, you're going to get the denial. If you write it in there, it's going to get approved.
Exactly.
So let's say you write it as monotherapy for a patient. They go home, start using it. What can we expect outside, as far as efficacy, or what do you usually counsel your patients on? When it's going to kick in, and how much improvement to expect, or when to come see you if it's not this percentage better.
Right. Yeah. So I always, in my practice, I always set expectations low, because I think that if they do better than that, they're pumped, right? So I always say, with both atopic dermatitis, psoriasis, seborrheic dermatitis, these tend to be more chronic diseases. And so we're probably not going to see maximal efficacy till about 2 or 3 months. And so you have to kind of keep with it. But I'm hoping that they're going to start seeing results, in the first few weeks, and they'll be very excited about that. It kind of motivates that compliance that we talked about in the last episode. But with Zoryve, for the atopic dermatitis and the psoriasis clinical trials, initially, they actually had 4-week endpoints. And so again, again, we know that ZORYVE will start to work very, very early. For atopic dermatitis, I think it was about 30 to 40% of patients were already clear, almost clear at the 4-week point, and then it just kind of continued to improve, from there, which is great. Once daily non-steroid, I think that's really powerful, right? We don't think about that. Like with steroids, I think we would expect that, but with a once daily non-steroid, I think we have to reset our expectations of what we can now get with a non-steroidal therapy.
Yeah.
And then for subderm, actually, the endpoints were at 8 weeks. And at the end of 8 weeks, 77% of patients were almost clear on their subderm.
crazy.
That's really high numbers, right?
I don't know the exact number for ketoconazole, but it's probably 2%.
I don't know.
No, I don't. That's not it's a compared to treatments that have been so ineffective to having something that effective is amazing.
Now, again, with the new psoriasis foam, we're seeing very similar numbers. Like over 60% of patients are getting almost clear scalp psoriasis, and then pretty close numbers in the body psoriasis category is also with that foam. So again, a once daily non-steroidal topical giving us pretty high efficacy. It's really powerful for our patients.
Yeah, that's incredible. It's actually really helpful to know to keep going past a month. It's helpful to know because some patients are like, okay, well, do I add something on right now? Or you're like, no, it's going to continue to get better month 2, month 3.
Right.
And then, like you said, if you're seeing improvement, they'll keep going. If they're not seeing anything, it's hard to do something for 3 months if nothing is happening.
Yeah,
right? But if they're
all
seeing
of the
improvement,
studies, they did see that the itch starts to improve even before the rash starts to go away. And so I think, again, that, once the patients start to feel the symptoms getting better, they'll stick with it. They see the hope. And so then soon the rash will kind of follow.
And
afterward.
actually, we've all seen that in our clinic. Patients just want that itch to go away.
Yes.
First, actually, more than anything.
Absolutely. I don't care what my skin looks like as long as you take away the itch, right? How many times have we heard that?
Yeah.
So
100%. I can imagine for the little ones, like with atopic derm patients too. I mean, it's a whole thing. It's like a whole family disease.
Totally.
When a kid is itchy, they're not sleeping well, maybe they're not doing as well in school. It's
the
a
parents
whole
aren't
thing.
sleeping. Yeah, totally.
Yeah.
Totally.
No, my gosh, that's fantastic. Is there any specific data? I know we talked in the last episode about specific sites, special sites, genitals, scalp. Is there any specific data for any special sites, hands, palms, soles?
Yeah. So for both the cream and the foam formulations and all of the different indications, the patients were able to use the medications on their whole body, and so they did do sub-analyses where they looked at scalp, the genital areas, and saw that it worked good. Worked well across the board. Really high efficacy in all of these sensitive areas. Again, areas where we might not be able to use a steroid long term for 8 weeks, potentially. But with the non-steroidal, you can keep going until you get to that efficacy that you want.
Yeah, it's good to know because sometimes you think of certain areas as tougher, but actually I've seen patients with ZORYVE do really well in palmar, which sometimes you think of that as a more calcitrant area, and for some reason, and this is just has to do with
it's harder to treat.
It is harder to treat. And for some reason, I think it's just
longer.
Behavior. We just think, well, the steroid is going to be the way to go. But I don't know if you've had the same experience. I've seen great results. I don't know if it's just easier to apply.
It's possible.
And patients are using it more versus our greasy ointments that we're giving.
Or again, getting back to that formulation, right? Is it able to kind of penetrate through those thick layers of the stratum corneum that we see on the palms and soles, even though the formulation actually doesn't have any penetration enhancers. But somehow it's able to kind of still have the effectiveness.
No, it's so important actually. We talked about the last episode, vehicle is so important.
Yes.
And that's not always looked, I think the best cosmetic, lines look at that, but it's not always carried over to the prescription line. So that is fantastic. How are you kind of doing? Because I know with this steroids, we talked about the chart and we say use this twice a week and do this and all this. Are you still doing any of that tapering, or because it's once a day you can use it forever kind of thing?
Yeah.
How would you counsel on, okay, once you reach clearance, which we know the large majority of patients are going to reach that pretty soon, which is great. Then would you do for maintenance? Do you still do that the sequential therapy, or go to the Saturday, Sunday? Or
So the long-term studies for ZORYVE, they did exactly that. So they treated every day until they were clear, and then they were able to go down to twice a week for maintenance. And that's kind of what I do in my practice as well. So I say then you can just throw it on a couple times a week just to keep the skin under control. And then if if you start to notice it coming back, go back to daily use. And I think it makes more intuitive sense to patients. Like the more disease I have, the more I use it. The less disease I have, the less I use it, right? Versus like use the steroid when it's bad and the non-steroid when it's good, but you still have to use it every day. And so I think that strategy is it makes a lot more sense to patients.
No, it makes a lot. Actually, even just hearing it that way, like psychologically, I feel like it's an easier thing to do versus being like, oh, now it's bad. You got to go to that medicine that has all those high side effects versus this is just like,
just use the same one.
You're doing good. Great. Just do it less. You need it more, use it more. And that's like, I think there's so much about like when we talk to our patients about chronic disease, like we give them the diagnosis and we're like, here you go, here's some medication out the door. There's so much around it and like the fear of the medicines and all that. I think the simpler you can make it, it's already kind of tough to wrap your head around. Okay, now there's something I didn't have to do before.
Yes.
Now I have to do all the time
every day
in the future. But it's like the more simplified we can make that, the less scary the medication sounds, which is sometimes with steroids, if you read all the
warning labels, right?
Things can happen. I mean, if you're on social media, you see all the sites or people, there's a lot of fear around it. And sometimes, like we talked about, if used properly, they're fine. But if not used properly, that's one of those other cases
where we're getting those stories
happening. Yeah. So I think it's great for patients just to make it simple, at least make the process simpler, just effective, simple.
Yeah, absolutely. And I think that, again, getting back to the formulation piece or the non-steroidal piece, I should say, is that I tell them at the outset is that you can use this medication anywhere on the body. So that way, like, let's say they go home and they didn't have genital psoriasis when you saw them, but they did develop it later. They know that they already have the tools to use and they don't have to make another appointment. They don't have to call in, to the office and say, what should I do? So it's also saving you time and saving your staff time because they already have the treatment that they can use in those areas should something come up.
Yeah, that's actually such a good point. I've had so many patients where they've even had like chronic eczema or they've had chronic psoriasis and they show me different spots on the body and they're like, is this the same thing?
Is this the same
thing?
Do
you get that all the time too? And I'm like, yes, of course
different.
It's the same.
Yeah.
Because it could look a little bit different.
It could look a little bit different. And so, and they're convinced that they have like multiple different things going on. And I always tell people like, common things being common, this is probably all the same thing.
Probably the same thing. And like, it's just our human mind. I always do this too. I try to justify something. I'm like, well, if that started last week, I know I was using that one thing over here. And so I think that's just great advice because I think that's actually a situation we see a lot where they're coming in for the same thing in a different spot. You could just say, and then they really don't know that. My patients will ask me like, can I use this cream there?
Exactly.
These are such like,
you
just
don't have
common,
to have these conversations, right? You've immediately cut out like hours of counseling time over the course of a few weeks.
You got rid of that body diagram where you had to draw, this, put this there. So it makes it simple once a day, put it everywhere. That's actually such great pearls. Listen, right off the bat, you're like, do these things and you do cut down the in-basket messages, which is something we talk about a lot.
Absolutely. It's taken over our lives.
So for multiple reasons, I think for patients, for physicians, having effective things that are simpler is better. Yeah. It's a better place to be.
Yeah.
But that's fantastic. We talked about access. I mean, I think the most important thing with access here is just right for the
right diagnosis, the right formulation for the right diagnosis. That's super important. And then again, if they have tried and failed any medications, even over the counter stuff, put it in the note because sometimes that can help you get the medication. And then if you run into a situation where it's not covered or it's getting denied still and the patient is commercially insured, Arcutis does have patient support programs and copay cards and things like that to help get Zoryve if
a lot of our patient
insurance is giving you a tough time. Yeah.
So those are great to know. And then there's always like in every area, there's those few pharmacies that can use those cards. And then there's the larger pharmacies that's going to hit and miss when you send your patient.
Exactly. So if you can send it to one of those, it's usually a little easier. But if not, and if your staff is well trained, you can kind of teach them.
Just going to have our patients and go through it. But that's fantastic. It's so great to go over everything. I'm just looking over here. Did we miss anything? We talked last about, of course, the mechanism. We talked about the vehicle, once daily use. Super effective. I mean, that's the main thing.
Yes.
Special sites. The genitals, important to just ask about it and tell people you can use this. Maybe we should even say, like, you can use this everywhere on your body, including
the genital areas, the armpits, the face. Yeah.
Absolutely. And anything else? Anything we missed there? I mean, I think it's just making it simpler is just so easy.
Yeah, absolutely. Yeah.
Because usually when we spend, on our podcast, we spend a long time talking about side effect profiles and how to handle that and how to counsel patients.
Yeah.
You don't need to do that here.
I think, the side effect profile here is really quite clean as far as we know with Zoryve. It's, like I said, no stinging, burning. The tolerability was really great. The PDE4 mechanism, we have used PDE4 in the past with drugs like apremilast or Otezla. So we know that there is a potential for GI upset.
Yes.
But with Zoryve, the numbers are really small. So, I personally have not had any patients who have complained of diarrhea or upset stomach or anything like that. But theoretically, it potentially could happen.
Yeah.
So it's up to you. I don't actually bring it up with my patients proactively. If they call in and they say they're having a problem, obviously I tell them to stop or cut back on the medication. But again, since I haven't seen it enough, I actually don't even include it in my initial counseling.
Yeah, because like we know with all of our other medicines, there are things that we take from the oral version of the medicine and carry it over on the topical. And many times, again, we've seen the absorption just isn't enough where you have to worry about that stuff.
And I think it's a little bit of an art. This is like going beyond this podcast, but it's a little bit.
It's the art of what you do, which is what we want to emulate.
It's a little bit of an art telling your patients what they need to know versus telling them too much and then scaring them away from therapy, right? Because some people, they want to be very comprehensive and they'll go over every little thing that's in the package insert. And honestly, it's scary, right? When you hear about all these things, you're like, well, one patient died of, cardiac disease. That did not happen in the Zoryve trial.
No, the Zoryve trial, but you're right. Yeah.
But just in general,
anything at all, or if you just see the risks of like going outside your house,
right,
it's true.
Right.
Like what's relevant to you right now.
I tell them what I think is relevant, what is most likely to happen. And that's how I present it to patients. Because again, if the conversation's too long and drawn out, you've lost them, right?
You've lost them.
You need to stick with the bullet points
Yeah.
and the important things, and you need to make it relevant for them.
No, 100%. And that really is the art of medicine. And then it's like just putting everything into context. And we're talking about apremilast, which is a totally different medication, of course, but has the PDE4 mechanism. And even then with orals, we know of like the Dr. Koo method. He's like, keep cutting the pill. Keep cutting it further.
Exactly.
So
there are ways
you
that you
make
could...
the oral medication, the GI symptoms, minimize. So of course, if you're bringing it topically, you're even like less than that. So like you just have to kind of, there's the stuff you have on the package insert, and then there's real life, which is really, really kind of applicable. So that's fantastic. Yeah. Well, thank you so much for going over everything. And then I think it's really important. Topicals are still key. People want topicals.
Yes.
Even if they're on systemics.
Even if they're on systemics, they're still going to need a topical.
They're still going to need topicals. And the easiest you can make it and make their life easier, effective, it's important. So I think even though a lot of times we talk about the biologics, systemics more, the topicals do need kind of a lot, because we're actually prescribing them at much higher rates than any of the systemic medications.
And that's why I said, I think we shouldn't stop the innovation of topical therapies. We need to continue. We're investing a lot of money, research dollars in biologics and systemic treatments, but we really need to invest back into topicals too.
No, absolutely. It's actually, I don't think we realized how much we needed newer topicals until they arrived. I don't know if we're just, for some reason, we were like, well, this is all we do. We do steroids. But once like the innovation started and we're getting medications like Zoryve, we're like, oh no, you really can do it a little bit differently and have a paradigm shift. So let's go. Well, thank you so much for joining us. We learned so much, so many pearls.
Always love being here.
Fantastic. Thank you again.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.